Hello, everyone. Thank you for joining us, whether by Zoom or YouTube, and welcome to A Time to Speak Up, Learning and Earning Trust Between New York City Communities and the Medical System. I am Paulette Spencer. I manage community engagement and policy at Bronx Community Health Network, also known as BCHN. BCHN's leadership is delighted and honored to collaborate with Professor Eyal, his colleagues, and the Trust Project at Columbia University on this town hall conversation. Now, in our 25th year as a federally qualified health center and community-based organization, BCHN provides access to comprehensive quality primary care and related services at 20 partner community and school-based health centers. We are very proud of our innovative and community-centered health and wellness program that focuses on prevention, early treatment, health education, and health literacy, and connects thousands of Bronx residents to many needed resources. Our outreach specialists and community health workers address the needs of people and families in our communities, such as access to food, housing, jobs, and support for pregnant moms to help them better manage and overcome health concerns and chronic illness. I first met Professor Gil Eyal, who teaches in the Department of Sociology at Columbia University, at a launch event for the Precision Medicine Initiative at the school 2 years ago. He mentioned that he was seeking funding for a seminar on community trust in medical institutions and invited me to stay in touch so that he could learn about our work. I was very happy to receive his invitation to partner on tonight's event. The importance of our collaboration in this project lies in a mutual understanding of the quality of pre-existing relationships between community residents anywhere, medical experts, and medical systems, especially during a crisis. Those relationships determine the level of trust and compliance that is possible when the community is asked to adhere to public health recommendations or directives, such as participating in medical research studies or getting vaccinated. Of course, trust is built through communication and the integrity of one's actions, and not only by listening and engaging in dialogue. BCHN's work at the community level through our community health workers forms one of the trust building links that we will be discussing this evening, such as participating in medical research. It is now my pleasure to introduce Professor Gil Eyal of the Department of Sociology at Columbia University.
Thank you, Paulette. As Paulette said, my name is Gil Eyal. I'm a professor of sociology at Columbia. I'm honored to co-convene this event together with my colleague Paulette and with the wonderful and dedicated people at BCHN. You may want to ask, why is a sociologist involved in a panel that is about health and medicine? What sociology got to do with it? The answer is simple. You can have the most advanced and sophisticated medical treatments, but if people can't pay for them, they're not going to do any good in the world. If people don't know about them, they're not going to do any good in the world. And if people don't trust the institutions and the professionals who offer them, they're still not going to do any good in this world. But trust is not something that a doctor can prescribe, and there's no vaccine to inoculate against mistrust. Trust is something that you have to build over years. It requires investing not in expensive medical technology, but in relationships, networks, and communities. Things that a sociologist knows something about. Now, we are in the middle of a pandemic that took an incredible toll on Americans, but even more so on people of color right here in the Bronx and other boroughs of New York City. In the midst of the pandemic, everybody wants to know, why don't people trust public health experts? Why don't they trust the vaccine? The sociologist knows that these questions are hasty. They ignore the long history of discrimination and underinvestment in relationships, networks, and communities. They assume that you can flip trust on like a light switch. It doesn't work this way. At the same time, we are in the midst of a pandemic. If you look around the world, Many of the countries that did better overall are the ones where there is social cohesion, there's less inequality, and there's more trust in experts and institutions. This is a time when the need to earn trust and to learn how to trust is urgent. We intentionally chose a title that indicates that there are at least two sides to this task, if not more. But the questions for the panelists is, how do you do this? How do you earn trust after you've squandered it? Or how do you relearn to trust after you've had too many experiences to the contrary? And how do you build trust maybe from the ground up where it didn't exist before? We could have convened a panel of academic experts to talk about these issues, but I think this would have been a mistake. Earning or learning trust can only happen through dialogue. Only through dialogue you can come to understand the point of view of the other person and maybe move a little bit from where you started. This is why we wanted to have a conversation in which people from the community can speak up and pose the hard questions. But this is also why it was important for us that people will hear from community health workers, because they are in a unique position, standing between ordinary patients and the medical system. And they know firsthand what works and what doesn't in terms of establishing trust. This is why our panelists and moderator are all people who are embedded in the community, representing organizations that are all present in the Bronx and working on this issue day in and day out. Now, we will begin the program with a short 3-minute statement from the panelists, who will address the question of trust in the medical profession by drawing on their own personal and professional experience. We'll then open for Q&A from the audience, take questions that the audience would like to pose to the panelists. During the Q&A, we'll also invite community health workers, CHWs, to take the stage and talk about their work of serving at the intersection of the medical field and patients. Community health workers have a unique position in which they negotiate and mediate between doctors and patients on many issues, including vaccines. After we hear the last testimonial from one of the invited community health workers at around 7:45, we will launch into the last round of rapid questions and answers and conclude the town hall conversation at 8. Paulette, the floor is yours if you can introduce the panelists.
And now, without further ado, it is my pleasure to introduce our 6 panelists. This will be Dr. Olusimbo Ige. She's the Assistant Commissioner for Health Equity at the Department of Health and Mental Hygiene. We have Ms. Patrizia Bernard, who is the Community Health Worker Supervisor at the Bronx Community Health Network. We have Dr. Monique Guishard, who is Associate Professor of Psychology at Bronx Community College, as well as a Vice Chair of the Bronx Community Research Review Board. We have Mr. Sergio Matos, who is a community health worker, as well as the Chief Executive Officer and founder of Health Innovation Associates. Ms. Diya Basu-Sen, who's the Executive Director of the SAPNA Foundation. And we have Dr. Sarah Malik, who is a practicing physician at the Montefiore Medical Center.
Paulette, I see that the Reverend Dr. Phillips has joined us. Yes. We were very lucky to have her. So if Dr. Phillips, maybe you can take it up from here.
Thank you so much. What I want to just tell you a little bit about what I do and why I think it's so important. I work for Weill Cornell Medical College Clinical Translational Science Center. So I work for the research arm of Weill Cornell Medicine. And what my job is, I manage various projects and I get the community involved in clinical trials and in research. I help educate the community so the community can do their own research projects. And right now, I'm challenging community members to get involved in research because I do believe that that is so important it's an avenue for the community to develop trust with the medical profession, but the community has to be at the table. So my big cry is community members come to the table, community members get involved, come be involved in the translational research process, because we have room at the table. We have academicians, but we need community people. And I think the trust will come from that interaction, that needed communication, that communication that will take us from where we have been, which Dr. Guishard has so beautifully stated, to where we need to go. So with that said, I'm going to start again, and all the panelists will answer the question: how would you define trust and its role in relation to the medical profession and medicine? Right now, I will be calling Dr. Monique Guishard.
Good evening, everyone. Thank you, Dr. Eyal, Ms. Spencer, for this invitation. 3 minutes is not a long time to make an impactful statement, but I'm finna try tonight. I think I timed myself to 3.5 minutes. Let's see. First, I want to acknowledge that I'm speaking as a descendant of enslaved Yoruba peoples, and I'm therefore ever a forcibly migrated, uninvited guest on Munche Lenape lands, colonially known as the Bronx. My statement this evening will center Black feminisms, and therefore it is at the intersection of robust, empirically grounded knowledge, but also lived experience of structural racism, sexism, classism, and ableism with US medical systems, though I am a researcher. My comments are fraught with skepticism, but also with hope for anti-racist, sex-positive, gender-expansive futures, wherein BIPOC folks exist and they thrive. To pose the query about how we can begin to learn to trust US medical systems, we must, for me, adopt a truth and reconciliation approach. Many of my students and fam from the BX Crib are in the audience, so let me break that down a little bit. It means acknowledging the harms caused, uncovering the facts, telling the damn truth. The problem is historic, it's systemic, it's not isolated at all. It ain't just the 40-year Tuskegee syphilis experiment, B. It's the legacy of the doctrine of discovery, indigenous genocide, land theft, and residential schools, stolen, dissected, and desecrated enslaved bodies, the birth of gynecology off of Betsy, Anerka, and Lucy's bodies, the sterilization of disabled women, of Minnie and Mary Alice Ralph, the North Carolina Eugenics Board, La Presión in Puerto Rico, the sterilization of women in ICE detention, the birth of virology on Mrs. Lax's stolen immortal cells that her family is suing to control the HeLa cell lines. It's the Guatemala STD experiments, the CIA-funded crack cocaine epidemic. It's redlining. It's racist, it's normative curricula and finance inequity. It's mass incarceration, the school to prison pipeline, and other manifestations, of the afterlife of slavery. It's the Kennedy Krieger Institute-led paint studies in Baltimore. It's voter suppression. It's state-sanctioned police violence. It's environmental racism. It's food insecurity, COVID evictions. All of these things cause high allostatic load, weathering, and premature death. To begin to trust medical systems, we must be mindful of these things that haunt, like phantasmas, like Jumbi, all of our interactions, the way you disrespectfully converse with us, the way you dismiss, the way that we narrate and talk about our symptomology, the way that you attend or do not attend to our complex personhood. To begin to trust means not gaslighting our embodied generational trauma, that you provide resources, reparations, real talk, necessary for us to heal. It means that we are not only invited into conversations about diversifying research agendas and experimental treatments, but that we share in decision-making and the monetary benefits reaped from research. It means co-ownership of research products too, and keeping your offers for pizza, your raffles for Amazon gift cards, and the supposed prestige of uncompensated consultative labor to yourself. Maybe then we can talk about trust.
So the next person that you're going to hear is Miss Diya Basu-Sen. Thank you so much.
Well, good evening, everyone. I'm Diya Basu-Sen, Executive Director of SAPNA NYC. Thank you to Columbia and BCHN for inviting me to be a part of this important conversation. I'm honored to be among this incredible set of panelists tonight. And I want to start by kind of acknowledging the importance of even the title of our conversation today, Learning or Earning Trust. I appreciate that conscious choice because so often we talk about mistrust of communities as if trust should just be given without properly acknowledging the failings on the part of our own institutions and the long historical context that leads to that mistrust. The onus is put on our communities rather than on our institutions to truly acknowledge the history and to actively work to actually earn that trust. Now, we've been hearing a lot about this issue of trust when it comes to vaccines, and the reality is that the concern is greater now because we collectively need these communities to be vaccinated for our own protection. But we can't build trust overnight when we're looking for particular health outcomes without putting in active work consistently and over time. We need more of this effort from the medical community at other times. It takes a consistent presence in the community, but also an effort on the part of providers to truly understand the communities they serve. SAPNA serves a largely Bengali community, and too often we find that providers who have a large percentage of their clients coming from Bangladesh haven't even put in the time to learn basic things about the languages spoken or the culture of the people. That basic cultural competence is essential when working with and trying to build trust with immigrant communities. Add to that the fact that many providers bring assumptions and bias about these communities based on what is either superficial knowledge or just plain bias. And that gap between these providers and the communities they serve widens even further. To give you an example, earlier this year, we were referred a woman for mental health counseling. And with the referral came a note that her mental health issues were most likely more religious-based. Now it's been about 4 months, and in all the conversations and sessions she's had, she hasn't mentioned religion even once, but she does wear a hijab. It isn't a stretch to think that some of those notes that we received were based on what they expected of a woman who looks like her and not actually based on anything she had actually said. To truly earn trust, the medical system first has to understand and acknowledge all the various reasons as to why there is a lack of trust to begin with, so that those root causes can be addressed. In some cases, it may not even be a lack of trust, but a lack of accurate, accessible information or misinformation. In other communities, it is a lack of trust. When the COVID vaccine first came out, a lot of our community members weren't getting vaccinated, not because they didn't want the vaccine, but because they didn't understand if they were eligible. It was too hard to make an appointment. And sometimes they just had a few questions, but as someone with low English proficiency and either on Medicaid or with no insurance, it was very difficult to actually find someone who would give them the time to speak to them about those hesitancies. We also have to stop making these communities into monoliths and understand that even within a group, there are nuances, and that while one strategy or stakeholder may work with one subset, it may not work with another. And frankly, there's also the fact that the medical system also needs to acknowledge that in some cases, they simply aren't the best suited, and that they need to effectively engage stakeholders like community leaders or community-based organizations who hold trust within the community. Thank you.
Ms. Patrice Bernard.
Hello, everyone. Good evening. Thank you for the opportunity of participating in this panel and participating in this very important conversation. My name is Patricia Bernard, and I am the Community Health Worker Supervisor at BCHN. It is very hard to follow the two speakers that have spoken before me, but I think that the conversation of earning trust is one that we've had for a very long time, right? Because of the pandemic now, and because of the vaccine, as has been mentioned, that conversation has come to the forefront. But for us who work in community and who work with community, it is a conversation that we've been having for a long time, and a conversation to which we've been trying to find solutions, right? So trust between communities and the medical system is essential if we truly want to live up to our values and ideals as a society and as a country. Many of the community members that we serve here in the Bronx are part of community are part of groups that have for a long time been stereotyped, as mentioned before, lied to, abused, exploited many times throughout history. And that has resulted in the disparities that we now see in healthcare, the persistent disparities that we see in healthcare and that we work very hard to reduce, right? And has completely eroded, in some cases, the trust that was there before, if it was ever there. So how do we build that trust now? How do we earn that trust? And I'm going to repeat some of the things that have already been said, because I think that we all agree on the topic. Number one, I would say ownership from the medical system, ownership and acknowledgement of what has happened in the past, of all those atrocities that Dr. Guishard so beautifully said and exposed. Having conversations with the community so that can be addressed and understood. This is the number one thing I would say. The second thing that was also mentioned is cultural competency, right? And that is something that we do at BCHN, having community health workers or having staff or doctors that actually represent the community, who understand the community, who won't stereotype the community, having leaders, having diversity also at the leadership level so that people who are making decisions know the communities that they're making decisions for, and more importantly, inviting the community to be part of those decisions, having open communication both with community and medical system. I will also say that it is super important, and we've noticed that in our work as community health workers, is to have patience. You have to have patience. We don't build trust overnight. We have to be committed to the process. We have to be there. We have to show up when no one is showing up. We have to answer the phone. That is how we build trust. Once the community sees that we are there or that the medical system is there, little by little, the wall will maybe start to come down where we can start building that trust. And lastly, I would also say understanding that we're dealing with human beings, not just medical conditions. It is not just a medical chart, but it's individuals who are complex, who have fears, who have emotions, who have goals, who have aspirations. And that's how they need to be treated. And I think in taking all those things into consideration and building a system that is more human-centered, we'll be able to start building trust. Thank you.
Thank you so very, very much. Now we will have Dr. Ige.
So I want to start with an acknowledgement. The speakers that have gone ahead of me have already, mentioned what is it that is driving trust, the mistrust. Many people of color have had bad healthcare experiences. Some have even lost loved ones to the shortcomings of the American healthcare system. So there is a collective understanding that in many communities, putting blind faith in the medical system that has failed them over and over again can lead to poor outcomes or even death. So in this context, distrust in vaccines or the healthcare system as a whole is a logical reaction, and it is a protective coping response to overwhelming adversity. So I want to start by acknowledging the historical and contemporary harm that have been perpetrated by the research, medical, and government systems on Black, Indigenous, trans, non-binary people, disabled people, immigrants. This has resulted in the rational mis or distrust in the systems. Reversing this mistrust will require that we start with an acknowledgement. And we want to recognize that we, as the government and healthcare institutions, have played roles in the traumatization of communities. Like any rift in interpersonal relationship, healing fractured relationship between the healthcare system and communities that have been most impacted by inequities will take time. It will not be comfortable and it will not be easy, but we are ready to do the work. We must promote cultural humility. We must avoid blame, and we must acknowledge the wounds of the past and the present. We must also prioritize transparency, safety, and preventing re-traumatization. It breaks my heart when, folks say, oh, if you're not vaccinated, you're a problem. We must empathize with those whose history and personal experience of discriminatory treatment and trauma makes them unable to jump on the bandwagon, makes them cautious. And so reversing that mistrust will require conversations on restorative justice, on partnership with trusted messengers, and innovative and culturally sensitive ways to share accurate information about the virus. But above all, we must demonstrate that the concerns of the community and their needs matter beyond the vaccine. We must be present. We must work with communities to provide a safe space for conversations to happen. And we must be committed to doing the work to educate and gather information from the community on their concerns. And this is how I think we can proceed. But on behalf of the government and the healthcare institution, we acknowledge that we have contributed to the status quo. And I think that that's the first step in repairing those relationships and rebuilding trust.
Thank you so very, very much for those insightful comments. I'm sure the community is really, really pivoting and taking them to heart. Now we will have Dr. Malik, who will give us her comments.
Hello, thank you so much for having me. I am very, very grateful and honored to be part of this conversation, to learn from all of you and to dialogue with all of you. And so I completely agree. So I'm a primary care physician and a clinician at Montefiore, and I work in a clinic in the South Bronx. And I think that the issue of trust in the medical system, I think that there are so many reasons for mistrust and distrust. I think these reasons are multi-layered and complicated and interlinked. I think at the systems level, as some of the previous panelists have really wonderfully described, there's so much on a systematic level. Our mainstream biomedical institutions have participated in the past in perpetuating institutional racism and systemic racism, and they continue to do so. There's no question that is happening. My reflections on trust and mistrust, most of them come from individual experiences with patients. I've heard a lot of patients and reflected on a lot of things that have happened while working as a clinician here. And so a few of the things I've noticed, for example, are, there's no question that the discordance between patients and providers when it comes to racial and ethnic and cultural backgrounds leads to a lot of mistrust. When we have mostly white providers and Black and brown patients, there's layers that are missed. One thing that I think another thing that I think has really contributed to this is how institutions really don't invest in maintaining longevity of relationships. And I think relationships have been mentioned before, relationships between providers and patients. And so I work in a teaching clinic, for example, which means that, it's an internal medicine clinic. We have residents that come in and then residents that leave. That means that 10 new doctors come to our clinic every year, and 10 doctors leave. And so when I meet new patients now, I've been there about 8-9 years now. When I meet new patients now, I ask them, how long have you been coming to this clinic? And some of them say, 20 years, 25 years. So what does that mean? That means that they have had 20 doctors or 15 doctors. And how can you have a primary care doctor if they're only there for 6 months, or you only know them for 6 months or 2 years? It's not enough. So really the lack of longevity in relationship is a huge, huge problem. And then of course, I think that there's so many examples of things that happen to patients and their families that lead to distrust. So bad outcomes, bad experiences with certain therapies or therapeutics or treatments, procedures. I think a lot of patients have suffered from the trauma related to, really painful conversations around end-of-life discussions, around end-of-life decisions for sick family members. There's so many examples, unfortunately. And so I look forward to talking to everyone more about this.
Thank you so very much. You've given us some things to really think about: trust, mistrust, racism, institutionalized and systematic racism. Thank you so much. Now we just have Mr. Sergio Matos, and he's going to make some comments on trust, mistrust, and the medical profession. And then we will we'll open up for questions and answers from the community for the panelists. So, Mr. Matos.
Hi, thank you, Dr. Phillips, Dr. Reverend Phillips. My name is Sergio Matos. Bienvenidos a todos. Welcome, everyone. I want to thank those of the speakers who spoke before me. And many of my comments will follow up on theirs. I do want to highlight, I like to place things in the context of history, and some speakers already have, but I want to highlight the fact that medicine in the United States was formalized in the late 1700s, early 1800s. I think King's College and Pennsylvania Medical School were the first in the United States, and they were in 1795 or so. And I say that to say that in 1800, when medicine was being structured and architectured and engineered and built, it was being built in the presence of a society that believed very firmly in slavery, in gender oppression, and in inequities. Our society believed those concepts were just. And so most of medicine is structured in a way that is irrelevant for today. We're starting to address some of these issues, and I thank Dr. Ige for her comments about the role of institutionalized and government healthcare systems. But all of those were created at a time when many of us know, from having studied our history or having heard our ancestors' stories of that history, that slavery was highly impacted by medical structures. So if you were a slave in the United States at the time medicine was being created, you could not go to a doctor because you were not a human being. So if you were a person of color and you got hurt out in the fields, in the cotton fields, you could not go to a medical provider. You had to go to a veterinarian because you were an animal. And that historical, we actually lucked out because veterinarians were much smarter than doctors actually at the time, because people valued their animals. So veterinarians were very learned and educated and schooled, while doctors were selling snake oil at the time. But in that context, people know this. People know that medicine was created at a time when we were forbidden from accessing it. And people also know about Tuskegee, as one of the panelists raised. People know about women being sterilized for experimental purposes by the United States government and researchers and academics. And so the question isn't really so much like, how do we get communities to trust the medical system? I think the question should be, is the medical system trustworthy? Is the medical system worthy of our trust, considering the structure and the engineering and the architecture that it contains? And I thank Dr. Ige for inviting us to look at that structure and see if that needs to be changed, because that's the root cause of the inequities that we're experiencing in healthcare today. We know as members of community that there are different systems of care depending on what your socioeconomic status is. We know that. We know that if you have the money, you don't have to see 20 different doctors. But if you have Medicaid, then you unfortunately, you might see 80 doctors in your lifetime, because there is no consistency. And so I do want to share one slide with you. I don't normally use slides, but I'd like to be able to share this with you. And the purpose of this slide is to show you that there are 4 pillars to building trust. And they are ability and competency, compassion, communication, and consistency. And a lot of the panelists already mentioned these. But I want to say that in terms of ability and competency, the medical system is really very recognized. People give the medical system a lot of status for their ability and competency and education and skill. As far as compassion, that could be iffy, depending on people's personal experiences. Whether the medical system is compassionate or not is really a personal experience. Communication, I would say, is pretty lacking, especially two-way communication. Communication in medical interactions tend to be one-sided and prescriptive, not necessarily two-sided or open, or even relevant to the person receiving the conversation. And as was mentioned by several people, consistency is quite weak in the medical system. Now, these are the pillars. These are, if you look at trust as a chair, these are the 4 legs of the chair. And if you really consider this stuff, medical systems have 1 strong leg and 3 wobbly ones. So it might be time to look at repairing the chair and not the person who's sitting in it. So thank you for your time.
Thank you so very much for those insightful comments. Repair the chair and repairing the person that sits in it. Wow, thank you so much. Now, one of the things I'd like to add is we will be opening up for questions and answers, for questions from the audience, for the panelists. This is a question: how is the medical system currently lacking in teaching future healthcare professionals about earning trust, and how can curriculums be improved to help build a more trustworthy medical system? So we'll get a volunteer from a panelist.
I can start. So we still have a long way to go. Preparing the providers for the reality of their operational context after medical school is still very lacking. I'll tell you a few reasons why. As of now, less than 5% of the doctors in America are Black. Without more diversity and inclusion in the medical workforce, it is really hard to build trust. Some of the data that we have looked at has shown that when patients see providers that represent their community, that look like them, they have shared lived experience, they have better outcomes. I am not saying that the only way to get things done is to have more people of color in the medical profession, but it is a start. It is important. When people don't have those relationships and those experiences, they don't even appreciate some of the challenges that people of color have, no matter how much you try to train them to recognize it. So those relationships are important to even understanding what the issues are. So that's one piece. So getting a more diversified workforce is important. Being intentional about the training and the education of providers and the relationship with their patients is important. It's not that providers are not capable of compassion. They just choose who to express that compassion to. So it's not about them not knowing how to build trust. It's that is selective who it is offered to. And that's the inequities that we're trying to solve for. So highlighting those inequities, there's a lot of work to show how healthcare is segregated in New York City, where there's certain healthcare system that only serve certain kind of communities. And if you go to the same healthcare system in Chelsea, the care that you receive will be different from if you go to a healthcare system in Jamaica. And those things should not be so. So highlighting those inequities in the experiences that people have, having accountability structures in place that ensures that these things are being discussed and that the things we put on paper and say that we are committed to these principles, we all write it down, we all say these are the values, but that there is no accountability for how we're really living to those commitments as some strategies that we can begin to take to help repair trust, the interaction between providers and their patients. How do we make our patients feel? Do people feel comfortable? We have some work going on in certain places where people will say, I don't want to go to that healthcare system. I prefer to go to other places because of the experiences they've had there. So those are some of the issues that we need to work on in the medical system. And we have begun those conversations. We now have at Department of Health, a chief medical officer in the Center for Health Equity and Community Wellness that is beginning to look into those things and beginning to advocate for some accountability structures. And one of the first steps is this declaration of racism as a public health crisis and putting real workable action steps into place for how our healthcare systems can be more responsive to the communities that they serve and accountable.
Thank you so very much. Putting different things into place so we can have more Black MDs, more culturally present and available to interact with their clients. Thank you so very much. Okay, we have several more questions. What are key action steps to dismantle inequitable practices for community health workers and healthcare systems, especially honoring their lived experience and being within the community? And how do we have stronger partnerships between healthcare systems and CBOs where community health workers work who understand racial inequities in our communities? Okay, do we have an answer for that one?
If I may, I'd like to speak to that.
Okay, thank you.
There's a couple of things. Number one is the medical system is geared towards all power belonging to the medical provider, the physician, and they're the ones primarily responsible. And that has a lot to do with insurance, not really care. But diversifying the healthcare team and integrating CHWs with dignity and respect as a member of that healthcare team would be extremely beneficial. Number one, the team would be able to address the social determinants of health, which are really at the core of the inequities that we're experiencing. And number two, we have a doctor shortage. So having other team members like CHWs deal with those other issues would free up the physician to do physician work, which is what we need. We don't need physicians trying to figure out how to get you food. We need physicians to do the stuff that they were trained so extremely at and that they're so good at. We need to free them up so that they could do that, but they need to be able to share the power that they have, which is often unearned, but they have it. And if they can redistribute that power, then it would build an equitable team that could help improve outcomes and improve people's health. Not just the absence of disease, but improve their health.
Thank you so very much. Thank you. I have a question for Dr. Malik. And the question is, the problem is often framed as the fact that patients, especially from communities of color, are mistrustful towards medical professionals and the medical system. But what about the other way around? Are medical professionals often mistrustful of their patients of color?
Right.
Are there ways in which the institution can work to encourage, to create a more trustful environment? How can things be changed?
Sure. So thank you for the question. I think, I mean, there's no question that doctors don't trust patients. There's no question that doctors make judgments very quickly, lots of stigma in the hospital, lots of attributes are assigned to persons of color, whether it's, someone being having more substance use issues, having more pain, having more, not being able to follow directions, not adherent, not working on weight loss. Like there's so many examples of how these labels or these attributes get assigned to people of color, and it reflects really like a sort of lack of communication, but it's rooted in deep biases. And I would say that's very much in the culture of mainstream biomedicine, for sure. In terms of how that can get better, I mean, I think there's definitely been interventions. I think they're just the beginning. It's just like literally like the surface, addressing the surface, which is like implicit bias trainings and things like that. And I think, of course, like there's some people who do that work very wonderfully. I mean, again, it's a 2-hour training is not going to change, is not going to address like root causes. I will say that because hearts change and people's minds change, including doctors' minds, when like doctors actually spend time with patients. Like if the system allowed doctors to spend more time with patients and actually allow for conversation rather than like type, look at the patient, type. I mean, like doctors don't talk to patients anymore, right? Like this is our reality. And it's also the reality of other other providers on the team as well, right? There's so many protocols and so many like hoops to jump through for everything that you want to do one simple thing, and you are like, it takes 15 minutes. I mean, it's a small point, but like over the last 5 years, there's been a lot of like authenticated like things needed on my cell phone. Like I need to look at my phone to prescribe something now, which means my phone needs to be present in the room with a patient. And like that, it may just be like, oh, it only takes 10 seconds, but it's actually very distracting to have a computer, a phone, this and that. And that just, again, deters from like real relationship building and like real conversations.
Real conversations with real patients and real doctors. Thank you so very much. I have a question now for Dr. Ige. And the question is, are there attempts to direct disinformation specifically at people of color? And thereby it amplifies mistrust in the vaccine and in the medical system. If so, are some of these attempts effective? What makes them effective? What can we do about it?
Right. The answer, unfortunately, is yes. There is very targeted misinformation at communities of color. One example was a recent video that was released by an anti-vaccine activist. These videos play on the history and the experience that communities of color have, and plays on the fact that they have been so horribly abused by the medical community, and which makes communities of color more likely to believe that the government, medicine, and research is out to get them and not actually helping. So that has fed the fear that many people have about the vaccines. And there's some other research that have been done that indicates that false narratives in documentaries, in social media, leverage this as, the crux, like this is injustice. It is framed as injustice. It is framed that as taken away choice. It is framed as experimental. So these are some trigger words for the community. There are links to words like Tuskegee's study on ethical experiments. These are some of the things that we see in many circulating misinformation. And another thing that we found from our research is that a lot of the misinformation that we see on social media is produced by a very limited group of people. It's called the disinformation dozen. It's a group of people that are responsible for 65% of the anti-vaccine misinformation on social media. So these 12 people are behind most of the vaccine hoaxes that you see on social media. They churn out videos, sometimes as much as 10, 20 per day, spreading scientifically disproven claims and conspiracy on what we call Black Twitter and other kinds of platforms. So one thing is to ensure that folks have this information. And I in my conversation with communities is, who do you know that has been vaccinated? How was their experience? Talk to people that from your communities who have been vaccinated about their experience to get to the truth. We know that providers continue to be a preferred source of information in many communities. Talk to your provider. And there are other trusted sources of information to check what is being spouted on social media, encouraging people to not take social media as gospel truth, but to also find out from other more reliable sources what is truly the experience. I say to people, if 6 million people in New York have been vaccinated and are doing well, some of this scary stuff that is being touted cannot be hidden. In the United States at this time, over 183 million people have been vaccinated. 183 million people. So that's a lot of people that have been vaccinated. So when we see these videos on social media, it takes things out of proportion. People are terrified and are scared, but how do we help folks to get perspective? Elevating community voices, elevating testimonials and stories from real people around them. And you will notice that some of the PSAs that you see on TV have changed to start elevating community stories, experiences of real people, and not just the face of a provider or a Department of Health doctor saying this is good for you, but experiences of other people in the communities to help reassure folks that these vaccines are safe and are the right way to go.
Okay, thank you so much. I have a question from the community. If organizations and medical professionals and you as a speaker are aware of some of the reasons that the public struggles to trust science and the medical system, are there any current efforts in process? Is there anything going on to address this and for possible change and for implementation? So we'd like one of the panelists.
So I'm an associate professor of psychology at Bronx Community College, but I'm here in my capacity as the vice chair of the Bronx Community Research Review Board. The way that we have been intervening in this conversation on mistrust is a couple of things. One, language is an issue. Can we acknowledge that? Language is an issue, right? And I'm not just talking about quote unquote foreign languages. I'm also talking about the fact that physicians and nurses and other folks speak in scientific jargon,
right,
or in ways that are not accessible to their patients. So someone who was talking before about adherence, I can't be adherent to your protocol. I don't understand what the hell you're telling me to do, right? So what the BX Crip does is very much like Weill Cornell. Before Weill Cornell, actually, we had a research academy where we taught Bronx patients and caregivers the language of research, Before someone out jargons you be, this is what that word means, right? So we do a lot of radical unpacking. And we also teach Bronx patients when people try to use those terms to demand, academicians and physicians also love to speak in acronyms. Oh my goodness. You know how many meetings, Dr. Malik, I went to where people were like AECOM. And I was like, what? To learn that was Albert Einstein College of Medicine, right? Like we do this thing where we abbreviate things all the time. And we do that because we have our own culture and our own way of speaking. So we have to stop that, right? Because we are broadening the divide. Another thing that the BX does really quickly is we review research studies that claim to be community-centered and community-based that are geographically located in the Bronx. And we've been invited to review studies in Colorado, in Louisiana, so many places, right? And we are not an institutional research review board. For folks who don't know what I mean, the Code of Federal Regulations says that every institution that conducts research and gets money from the government has to follow particular rules and guidelines about the conduct of the research, how risk benefits are communicated. We do a little bit of that, but we also vet the studies for what is in it for the Bronx. What is in it for us? Mm-hmm. And when are we going to get your results? And we don't mean in a paper, right? I might read scientific papers, but my mama don't, right? So if my mama's a participant in your study, when are you going to share back what you did with her data? So one of the things that we do is demand the swift return of research findings. And that's another thing that we have to talk about that broadens this divide.
Thank you so much. Now, Ms. Bernard.
Yeah, I mean, I would just like to add to that. I think that some of the things that, and I think Sergio Matos alluded to that as well, some of the things that we know work, right? But we need the health system to really invest in that in a way that is sustainable is community health workers, because they're members of the community, because they speak the language, because they have the similar lived experience, they have the cultural knowledge, they just know how to talk to folks, they have the patience, they have the time. But what happens is that, we get grants for like this project for maybe 5 years, 3 years, and then it's done. And then what happens? We need people to really say, we've done the work, we know that it works. Are you really now willing to put in the money and sustain the workforce that can do that work?
Right. Okay. Thank you so much. Now, something, one of the things that is coming up is the trusted messenger, because a lot of this has to do with that. What is the problem? So when we talk about a person getting involved and talking about research to the community, talking about the vaccination to the community, there's the potential problem is that person is the trusted messenger. How long will he be the trusted messenger? Is he the spokesperson for somebody else? Or is he the spokesperson for the group? How long can he maintain that position? And if he works hard, can he keep that position, or will he have to eventually distance himself from that position in terms of being the trusted messenger to the community? So the other question is, how do you feel, and this is going out to everyone, how do you feel when you're thinking about occupying a place between the community and the medical system, or the community health worker in that role between the community and the medical system, and they're trying to overcome the problems within that system, the problems that they have to work with? So being a trusted messenger, is that an easy position, difficult position? Why?
Yeah, may I address that?
Sure.
So trust is part of the definition of a community health worker. There is a federal Department of Labor definition. It's a job category in the federal government, and it's identified as a trusted member of the community they serve. So a community health worker's trust from their community is not for sale. It's not for sale to a hospital system or to any other medical system. It belongs to the community. It is the community that has given that community health worker that trust. And if they betray that trust, they cease to be community health workers. They no longer fit the definition of what a community health worker means. Now that's profound.
Yes, it is.
If you consider the consequences of that and the thin line that community health workers who are serving as liaisons between systems have to function on. I put actually in the chat, I put a link to a documentary of when the Young Lords took over Lincoln Hospital back in the 70s. And you might want to look at that. Because, and I want to add this to that, what Dr. Ige said, but the message doesn't always come from the medical system. The medical system needs to be open to the message you see from the community. So communication is a two-way street. It's not just employing CHWs to deliver a hospital message to the community. That's not the point. Medical providers are service providers. We pay them. They don't do this for free. We pay them. So if they can't speak up, if they can't speak to us, then go somewhere else where you can be heard. I mean, if the bodega doesn't speak my language, I go to another bodega. You know, a physician is the same way. If they cannot communicate with me, I am not a member of the medical culture. If you can't speak to me in a language that I understand, I'll go find somebody else who does. And I think, medical providers, we don't need to adapt to them. They are our service providers. They need to adapt to us, to serve us, because we are their service population. We're not the victims here. You know, we're not the ones who need to change. The people are being served or not.
I'll also add something, just being like from the community, community-based organization. I think we often also fill kind of a similar space of being a trusted kind of intermediary between kind of different institutions or the community and institutions. And I think what's often assumed, or the role that we're given, is that, okay, here we want you to do this legwork of passing this information along to the community. But as Patrizia said, there's oftentimes no compensation for that. That's just kind of assumed that we're here to do that work for free. And that work doesn't take time and doesn't have value in its own, that as kind of institutions should be compensated. And I think conversely, also the other issue that comes up is you're assuming that the things that we are kind of referring people for, that service is of a quality that we feel comfortable referring people to. So we've talked a lot about vaccines, but one of the issues that for us comes up is with mental health services. And one of the reasons we actually hired a mental health counselor of our own is because there weren't providers that we could actually refer people to. And recently we were offered a contract to kind of refer community members because they weren't getting people to come for services, and they wanted us to just kind of pass through people to the institutions, but they had no guarantees on the other end that they would actually have providers who spoke the language, who had cultural competence, who had kind of the expertise to work with our communities. So you can't just expect intermediaries to do the work without also putting in the work yourselves.
Thank you so much. Everyone has to put in the work. I have another question for the panelists. Experts warn that the next pandemic might be a not so distant possibility. What kind of legwork needs to be done today to prepare the community for a future public health crisis and avoiding repeating the mistakes of the present one?
So I can share a few of the thoughts that are going into this. You may have heard that last week, the mayor announced the Pandemic Response Institute that is going to be co-managed by Columbia and CUNY to help us think about some of this, the learnings from this pandemic response and how to prepare for the future. You know, it is clear that there will be outbreaks, disease in the future. That's a given. Every now and again, something crops up that we didn't know about. So that's going to happen. But how do we prepare for a response that is equitable. That's a big concern. So that is one strategy that's being used. Also at the mayor's announcement was also the public health court announcement. One of the lessons we learned during this pandemic is that the community partnership and relationships are so vital. Folks are not going to come to the website to get information. Not everyone is tuning in and listening to the PSAs we're doing in English on whatever TV station that we're putting it on. So we are losing a critical proportion of the residents of New York and across the country because we are not able to connect to them. We're not able to get information across to them in the way that is culturally and linguistically appropriate. And the community partnership that we've had in this pandemic has been really, really the key to the success that we've seen. So the Public Health Corps is a partnership with 100 community-based organizations and encouraging them to bring on board community health workers. Right now, on any one day, there are about 500 community health workers through all of these different organizations that are out in the community having one-on-one interaction across the city about this vaccine. And this is why right now we can say we're at 85% vaccination coverage in New York City because of the work that our community partners are doing, including our faith-based. We have at least 700 houses of worship that are partners in across different boroughs. So how do we preserve that kind of structure? How do we get funding to support that kind of community engagement effort? This is the first time we have a community engagement branch in an emergency response. And we have seen how that has really helped. And so we are really working to see how that can be a structure that will be sustainable and we can use for other kinds of health engagement.
Thank you so much, Dr. Ige. Now, some people are familiar with community health workers and some may not be that familiar. So right now, what we're going to do is we're going to have testimonials from community health workers talking about their work of serving at the intersection of the medical field and with their clients or with their patients. The community health workers have a unique position because they negotiate and mediate between doctors and patients on many issues, and that includes vaccines. Now we will have Romelia Covacho.
Thank you. Thank you so much for this opportunity to share real information that is dear to my heart as an advocate, as a trainer, and as a community health worker with 16 years of experience in this field. Currently, I am the Health Equity Manager at Health Literacy Partners. I am excited to see how the role of the community health worker has evolved and continue to evolve, and how this helping profession plays like an integral role in healthcare and public health to help our communities. Well, if done well. My experience in this country as an immigrant who had to learn a new language, understand a new culture, and frankly, the most difficult challenge I faced was learning access to healthcare services and navigating this complicated healthcare system in this country. And this made me discover a real passion for helping others like me. So I am not clinical. I don't hold a professional medical license, but I have the time to really understand, care, and acknowledge the clients that I serve. So understand their fears, their feelings, and really spending time knowing them, because that's how you build relationships. That's how you build trust, right? And we know that 70% of the people that come back to the emergency room is not because of their condition, but because of unmet social issues, because of the social determinants of health that you all been talking about. So I understand that achieving results, I have to to achieve results, I have to partner with the right medical system. So community health workers, we are public health workers who are trusted members of the community that we serve. And there are hundreds of titles, but so CHW is the umbrella title. And we are found working in communities where people may have limited access to resources, undocumented, not speaking the language, have different cultural and beliefs and backgrounds. So I think my success working with communities and the unprecedented opportunity to access, I have this access to the truth. And it's because I look to build community capacity. I work from the strength-based approach. I ask questions like, what are your hopes and dreams? And what was the time you had fun? And I feel like those forms, when I came to the country, and I feel like those forms that I received in the hospital were so insulting, were really intrusive and personal. And I didn't even know the reason why they asked all these questions that made me feel vulnerable and went home and cried. So I want my clients to be their own advocate. I want to coach them, I want to guide them, and I have the time. Time is the key. We community health workers have the time. So trust is earned, as we know, is not given. And it won't happen unless we give the appropriate time. And so CHW's work, like I said, to eliminate barriers for clients through community education, accompaniment, support, coordination of services. CHWs are able to assist the medical teams and access and how to utilize the health and social services that are so complicated and help their patients. But of course, the medical team has to appreciate and welcome our experience so we can partner with them. Thank you.
Thank you so very, very much for those passionate comments. Now we're going to hear from our last community health worker, Shirley Castro. Ms. Shirley Castro.
Hello, everyone. My name is Shirley Castro. I'm a community health worker for BCHN and Montefiore Medical Group. It is a true honor to be here with you all. And I mean, my fellow CHWs made a remarkable job explaining some of the things that we do as CHWs. As a community health worker myself, I often think of myself as the bridge, in connecting members of my community to the healthcare system. But also being the messenger often carries a burden because you're often the face, that's met, with frustration, with people's anger, with people's disappointment, and you have to have the patience and the time to peel all the layers, to be there and make sure that the patients feel heard, that they feel understood, that they feel, that you are able to connect to them in a human level. That is one of the ways that I, foster trust with members of my community. And is by looking at them as a whole person. Patient is more than their medical diagnosis. Sometimes we have to understand the environment that the patient is in, the challenges that they have, the barriers that they have, towards having better health outcomes. And, I am a community member and I am also a patient. So that gives me a level of understanding, and an ability to connect with the people that I serve. And like my fellow CHW, Ms. Corvacho explained, that we have time, working in one of the medical, Montefiore Medical Group's healthcare centers, I got to see head on the type of caseloads that providers often have. How they are overwhelmed and literally have to squeeze in patients and do the work that they need to do in a few minutes. And sometimes what you have is patients who are not fully able to explain what their concerns are or what they're going through. And then they're sent to your office, right, as a CHW, so that you're able to identify their social needs and see what way you can best help them. And it's in that room, it's in that space that you hear their stories, that you hear their challenges, their concerns, their pain. And that is what we have, time for these individuals to feel heard and understood. Earlier today, I enrolled a mother in the Healthy Start program. And as I was speaking to her, as a community health worker, we do assessments. We have questionnaires that we also need to complete in order to assess the needs of a patient. And during this questionnaire, I asked a simple question as, how much did your baby weight at birth? And she told me, I don't know. I tried getting that information. Everyone spoke in English, and I don't know how much my daughter weighed at birth. And something, as a mother myself, I'm like, wow. And as a CHW, I was able to go into the system and go into her record and say, your daughter weighed this amount when she was born, and these are one of the many stories that we hear when we are serving members of our community. I myself, as a community health worker, do have, my reservations when it comes to the healthcare system, but in my heart, it's always been a mission for me to serve the community and be part of the solution. So I often, provide education to members in my community and the effort that they can have a more healthier lifestyle. But yeah, I feel fortunate to serve at this level. And I am here because I believe that we need to learn how to earn people's trust. And it's not an easy task. It's something that will take time, but people know when you care. People know when you genuinely care for their well-being. So thank you all for having me here today.
Oh, we thank you for doing such a great job. And we thank you for doing something that so many people take for granted. And those are the little things. So everyone should know what their baby weighs at birth. So thank you so very, very much. All right, so let's go back to the panelists and let's hear their response to that, to all of the addresses that have been made by the community health workers. And while the panelists are coming back, I will add, at Weill Cornell Medicine Clinical Translational Science Center, one of the things that currently I've developed is a community research academy that is free to everyone, including community health workers. And it's all about learning the language of research. And it's for free because that's something that I think community health workers, everyone in the community needs to understand. So the program is open to everyone. But I think community health workers will love it even more. Okay, so now back to the panelists. Panelists, do you have any questions that you'd like to, or reactions that you had to the community health workers' responses?
Okay. I'm always totally impressed and motivated by listening to community health workers, no matter what. But I do want to thank them for the courage to come before this gathering and share their lived experience. It always motivates me. I think a lot of people mentioned a lot of the issues that we're aware of, and I'm also impressed with the sophistication, not only of the panelists, but certainly the panelists, but also the group here that's in attendance about the issues that are really at the root causes. And it sometimes seems overwhelming, as does the work of community health workers. But I do want to share a ray of sunshine in the very near future. And that is that if those of you who were involved, a couple of years ago, Dr. Mary Bassett took over the health department. And it was the first time we've had a woman commissioner. And she transformed the health department in major structural, sustainable ways. And it was really sad to see her leave, especially the circumstances. But our new governor, who is also a woman, has actually recruited Dr. Bassett to be the state commissioner. And that for me is a very encouraging note on which to sort of try to start bringing this to a conclusion. because I think she's brilliant. She is equitable. She is ethical, and she's powerful. And I really look forward to the immediate future with her in the leadership of the state. Wow. So that's my little ray of sunshine.
It's a big ray of sunshine. And I thank you so much for those comments. And community health workers really, they do an awesome job, and they're so very valuable in negotiating and communicating with people who are really having a hard time understanding the healthcare arena, period. What I'm going to try to do now is I'm going to try to take some questions. So we have a high school student, and he's interested in becoming a medical professional. And what advice would you have for the next generation of medical professionals? And this is for everyone.
Can I answer that quickly, Dr. Phillips?
Sure.
In my capacity in being a community college professor, even though I'm not a clinician, I would say, please, future Dr. Ashe, I'm gonna speak that into existence. Please take some ethnic studies courses. Please, right? Please don't just do the STEM courses and forget that through Black studies, Latinx studies, Asian PI studies, Caribbean studies, you are going to become acquainted with the histories of people that will be your future patients. Please do that.
Thank you. Yes, very important. Okay.
May I make a suggestion?
Sure.
As you go into the medical studies, you're going to be faced with enormous amounts of information and knowledge that you must learn. But I would beseech you to please, at all costs, hold on to your love, your caring, your devotion, your commitment to humanity. Don't let that get lost, because that's your humanity, that's your spirit.
In other words, go in with who you are, and remember who you are, and stay in touch with yourself. Don't lose sight of yourself through all the books. Stay focused. Okay. Another remark?
So I think those are great pieces of advice. I would also add to learn the history of biomedicine. It's also very important, because the way biomedicine is taught in medical school is that it's truth. And as Sergio described, right, biomedicine is not, it's only 100 or 200 years old. And there's a lot that's unknown, and there's a lot that doctors don't say because they actually don't know. And so to really understand all the systems in play that have made biomedicine the way it is and why it's so influential, I think it's sort of complementary to what are also very. I should also add that there are medical schools. I don't know about every single medical school, but there are some medical schools that are really critically reflecting on their own curricula and trying to incorporate more understandings of biomedicine from other disciplines. And I think that hopefully within the next 5 years, within the next 10 years, by the time you're applying to medical school, you can seek out those medical schools that are actually investing in these curricula.
Okay, thank you so very much. We need to understand that. That's stuff that a lot of us in the community are not aware of. So thank you. I have another question. How does the conversations between provider and patient start? Or should they start? Where should they start? Should they start on the patient level, or should they start with the provider? Where, how should these conversations occur, and when? So if patients want to know more in terms of developing trusting relationship with their healthcare provider, should they direct those questions directly to their healthcare provider, or should they talk to their community health worker? Who should they talk to about it? One of the things that you said earlier was the fact that where you're working is a teaching institution, so the physicians are constantly changing. So a community person may get a primary care provider that's here today and gone tomorrow. Who should they talk to about that if they wanted to develop some semblance of patient physician decorum or connection, so they could feel that, well, I belong here, and this is where my records are.
I mean, I can take that. So I think I'm really going to speak on 2 points. I think that one, the conversation, there are certain conversations that can happen in the exam room. I think that, basic things like acknowledging patients when you see them, eye contact with them, calling them by their name, like that in and of itself plays a role, right, in developing that relationship, and for the patient to feel seen, right? So I think that there's definitely room for that there. But I also think that institutions as a whole, right, need to create a way to elevate the voices for the community. They need to create a space where communities can share their experiences with providers, so that providers can also understand, because maybe providers are not even aware of, might not be aware, some of them, of what the impact of their actions, so to speak, are, or what the experiences are that those community members are experiencing. And so creating a space where that conversation can have place, I think, is essential. I think that some health systems are working in creating those spaces. I don't know how successful they're being, but I definitely think that there's room for that there, and inviting them also being part of not only expressing their experience, but also inviting the community in being part of the solution, because they know what works. We don't always know what it is.
Thank you so very much. And I understand what you're saying, creating a safe space, providing a space for that conversation to occur. Who should create the space? If a community individual went to the provider and said, we need a safe space to talk to our healthcare provider, do you think that would work? Or do you think they should go to their the nursing director, or should they go to that person in charge of community health work? Who should they speak to, just to start the ball rolling in terms of building a safe space for communications?
I think they should speak to everyone and anyone that they encounter.
So you're saying speak to everyone on the healthcare team?
The client is the payer. The client is, all services in a medical institution are supposed to be for the client. So that client should speak to everyone that they encounter and ask for a CHW. I mean, that's they're paying for the service.
Okay, let's hear from a community health worker. What do you think? How do you think how would you approach this? If a client came to you and said, my primary care provider isn't listening to me, or my primary care provider changed 5 times in the last 2 years, and I really don't know who my primary care provider is. Or even if I should tell my primary care provider certain things, how do you think they should approach this? Or the very fact that they share this information with you, what would you do with the information? Okay.
I was going to say that most of us have the ability to speak with someone in the healthcare center. So definitely giving the opportunity to patients to, to speak their concerns and to, to say how they're feeling and to express, the level of need that they have, we can speak on their behalf and advocate. That is one of the things that we do.
Oh, okay.
And and to also answer the question that was being asked before, as like, who do they talk to? I agree with Sergio. This is a shared responsibility, and everyone in the healthcare system has to be approachable and has to, take on the responsibility to create better relationships with the patients that we serve.
When I was growing up, I was always under the assumption that the healthcare arena was a safe space, but I'm coming from that culturally. So now it seems that the safe space is not as safe as I understood it to be. So now to address how we can turn the corner in many different ways, so we can, again, when most people, I'd say, would feel comfortable in the healthcare arena, and they will be able to trust their healthcare providers and the decisions that they make? Or do you think we've gotten to the point that we need to partner? Everyone, the clients need to feel like they are active partners in the whole, in the healthcare arena, that they're partnering with the healthcare providers. They're not just being treated and released without their own needs being met, so that they can, again, they can develop trust for the system, trust in the system, and trust with themselves, and trust in the decisions that they're making.
First, I guess 1 minute just to give flowers to all the CHWs here. I think y'all don't get enough, and you're really, I think, one of the solutions that we've seen come out kind of in more recent times that has been working. So thank you for everything you guys do. I think it was something that Shirley said about kind of seeing the whole person. And I think too often providers don't really see the whole person or take a holistic approach to their treatments or their interventions. So, I mean, I think I saw somebody in the chat talking about like changing diet, right? Diabetes is something we see a lot in our communities. And so often kind of our cultural foods are looked down upon. We're told, oh, don't do this, go to the gym, do that. But we're not really looking at some of the root causes, or even if some of those solutions are accessible for a community, right? A gym membership doesn't come free. So unless we're actually going to give those to people and give that access, or also, right, for some community members, maybe they physically can't get to one. In other cases, right, maybe people have food insecurity issues. And if we look at kind of food systems, that's a space I work in, the food that people get at pantries often are not good for diabetics, right? They're very heavy in starch and beans and pastas. And at the same time, right, those are the foods that are also cheap when it comes to going to a grocery store. So we're asking people to change diets, but we're not addressing the systems that cause them to have those diets in the first place, or giving them really suitable alternatives. And then we're accusing them of being non-compliant or non-adherent, but then we haven't, again, really addressed the issue that this is a client I have who has, I don't know, maybe they have linguistic issues, they didn't understand what I was saying. Maybe they have financial issues where some of the suggestions I made are not accessible. You know, maybe they have these other food insecurity or whatever other comorbidities, things that are going on, or maybe also they have mental health issues, right? That's leading them to kind of use food as kind of something that kind of helps their mental health. So if you don't really take the time to address and have that conversation and see the whole person, you can never really effectively address the needs, and then you wonder why they don't trust you or why they're not listening. And maybe it's not that at all. So I think that's really important in these interactions, to look at that whole person and the whole situation, and think about all the things that are interlinked and how we can really effectively serve them. And then I guess one thing just for patient side, what I tell everyone in really all situations is know your rights. Know what things you need to demand and what you can demand, and don't be afraid to ask for it, because what you don't ask for, you're never going to get. So be the squeaky wheel. Those are the people that, you know, get what they want. So don't be afraid to keep persisting.
Thank you so much. Persistence pays off. So we have a couple of minutes for a few more questions. So I'm going to add, this is one question. How do we establish accountability between an accountability for healthcare systems to be equitable for community health workers and partnerships with CBOs? How do we establish that accountability?
I think that some of the ways that are being put in place is the community advisory boards. Many healthcare systems now have community advisory boards where, you know, some of these conversations are happening. And I will also say, if there are CHWs that are hearing concerns about relationships and with patients, those are avenues for them to raise those concerns, you know, about experiences or services provided. So community advisory boards have become, you know, more widely used across the city in many healthcare systems right now. Another area where we're looking at, introducing some accountability is also with, community boards, where there is some influence with even with elected officials, and they have some advocacy power even for healthcare institutions within their jurisdictions in terms of their patient experiences. So these are other channels that we can use to hold healthcare systems accountable. Within the system itself, there is a lot of work now to ensure that there is an awareness and consciousness about these things within the healthcare system. We have a provider engagement team. We have provider detailing team. They go door to door with providers and have some of these conversations. How patient experiences are so important in terms of uptakes of services, and providing opportunities for patient advocates and CHWs. Again, one example is in the mayor's announcement last week, the Public Health Corps, there are going to be at least 500 CHWs through health and hospital systems that will be working with patients. So there is more and more recognition of the role that CHWs play in the provider-patient relationship. And we're hoping that we will see more of that, even with independent healthcare providers and safety net hospitals and our FQHCs or community health centers as well.
Thank you so very much.
I think that with these advisory boards should reach out to these community-based organizations where CHWs are, to get some of us on those panels.
Well, I'll tell you, over at Weill Cornell Medical College Clinical Translational Science Center, our Community Research Academy is doing just that. After we provide free education, we invite you to become a member of our Community Advisory Board. We invite you to sit in any of the cores in the Translational Center, Research Center, and voice your opinion. So I will send out a link for it, because I think it's important. So thank you so much.
Can I say really quickly, I think we have to pay some attention to financing.
Okay.
We can lobby our political leaders and our health leaders to dedicate monies targeted towards social determinants to support CHW work. And we can demand that money go to CBOs, because CBOs took a big hit with disrupt. Mm-hmm. And we need to reestablish that financial base for CBOs.
Okay, thank you. You're exactly right. Thank you so very much. I thank all of you for being here tonight and participating. I thank all of you for your voices. I thank all of you for sharing information that could not be gathered elsewhere. And I'm believing that from here, trust, the seeds, small grain, just like a mustard seed of trust, is being spread out and will eventually grow and bloom. With that said, I'm turning the program back over to Gil and Paulette. So thank you so much. And they'll offer short concluding remarks.
I want to thank everyone for sharing their pearls of wisdom with us this evening. And it was really quite a wonderful experience hearing about your experience from all of the your different viewpoints and where we converge, and the importance of a sense of unity in the work that we each do. And I also wanted to thank very much Professor Eyal for again inviting Bronx Community Health Network's participation or partnership in this endeavor. And it really means a lot, I think, to not only the people here, but to the community members who are listening to us right now. And we hope that this is the beginning of a wonderful relationship. I also wanted to say that for those who would like to follow the work of Bronx Community Health Network, you can always follow us on our social media on Facebook. You can reach us at our website, which is bchnhealth.org. And if you want to see what other activities we have scheduled, you can always look at our website, which is bchn.live. That is bchn.live. And so on that note, I thank you so much. And so many of you here responded to my invitation to be part of this. And I'm truly grateful. Thank you.
Thank you so much, Paulette, and all the other people at BCHN, Eleanor and Tashi and Patrizia for what was, I think, a very successful event. I really also want to thank the Reverend Dr. Lula May Phillips, who did this, heroic work of shepherding this panel. It wasn't easy all the time. There were questions coming from left, questions coming from right, from the Q&A, from the chat, from everywhere, but you kept us going. So that was great. And I also want to give finally a shout out for the people who made this event possible. Behind the scenes, you couldn't see, but there was a wonderful team that has worked for weeks now to make this event successful. I want to recognize Christian Capotesco, the Mellon Sawyer postdoctoral fellow, is the engine and brain behind this event. Danielle Thompson and Jack LaViolette, who are the graduate students who provided some of the magic that makes this event flow smoothly. And at Insight at Columbia, Michael Falco and Julius Wilson were so generous with their time and experience. And most importantly, Paulette Spencer was an indispensable colleague who has helped us assemble a panel of distinguished and diverse community voices, and without whom this event would not have been possible. And I also want to thank the Mellon Foundation, who gave us generous funds to run this event and others. Thank you.
And if I may add also Mr. Roger Newcomb, who is my public relations colleague. Thank you.
See you on the other side.